Hi, everybody. This is a very interesting, detailed, technical question here that I'm going to answer today, so buckle in. Just before I jump into the crux of it, if you could take a quick second to either like or share or subscribe or post a quick comment on my video, I'd really appreciate it. Just helps to grow my channel and social media presence and just gets more information out to more people that will hopefully help. So thanks in advance for taking a second to do that. So I'm going to read out the question here. It's a really good question. So it says, is there a way to differentiate between symptoms caused by MCAS, which is mast cell activation syndrome, versus reactivation of a pathogen versus immune overactivity to the pathogen, or kind of like an immune system hypersensitivity to that pathogen? And then she specifies here, that's a scenario where we might treat with low-dose immunotherapy / LDI. So it's a really good question. And I mean, quite frankly, there can be overlap with all of those things. All three of those things could be happening simultaneously, potentially, in a given patient. As per usual, nothing I'm saying should be construed as medical advice. This is for informational purposes only. If you need medical advice, please talk to your healthcare provider to get that advice. So I would say that probably the best answer to this question is it would really depend on what's triggering those symptoms. So if it's something that's kind of an obvious mast cell activator, so whether it's something stimulated by stress or maybe an exposure to like a known trigger, then that would suggest it's more of a mast cell issue. Or also like what makes it better would also help to differentiate if it's a mast cell related issue. So a mast cell stabilizer or a histamine receptor blocker or whatnot might, if that helps things to improve, there's probably a mast cell activation component. In terms of reactivation of a pathogen, I think it would depend on the circumstances around when the symptoms started up. So if it was, something that led to a notable immune system suppression, like say, too much prolonged stress, for example, or exposure to some toxic chemical or something like that, or something in that vein, and then maybe that led to an ability of, say, Epstein-Barr virus to reactivate, or perhaps the person has an issue with recurring or chronic strep, and so they were exposed to someone with strep throat, and that caused a reactivation of that pathogen, or kind of like a reinoculation of that pathogen. I mean, where it says reactivation, that's typically going to be specific to viruses, but it could potentially be a reinoculation. I've certainly had some patients where they get a tick bite and or some other like funky bug bite or something, and then all of their Lyme symptoms or Bartonella symptoms come roaring back or flare up, and so maybe there was a reinoculation at that time. So that would be kind of differentiated, I think, more so around what's happening around, or what happened around the time of the symptoms coming back, but there are the symptoms manifesting. But it would also, again, depend on what treatment's going to be helping. So if we start working with antivirals or antimicrobials, in the case of maybe like a Lyme reinoculation or whatnot, and then the symptoms get better, again, in hindsight, it would probably be more of a reactivation or reinoculation with a pathogen. And then in terms of differentiating that with immune overactivity to a pathogen, there's certain tells with that. Like, for example, if a person had a lot of issues with yeast and they eat sugar or something really sweet, and that seems to bring symptoms on like almost right away, that's oftentimes a clue that it might be something that low-dose immunotherapy or some other type of direct immunomodulator might help with, because generally, yeast can replicate pretty quickly, but not that quickly. So if it's like, oh, I react within like several, hours or a few days, then that's maybe more of like, oh, the yeast is just growing and replicating, and it's going to be more of an overgrowth thing, or like a reinoculation in a way. Whereas if it's like, oh, I eat sugar and like within minutes or like within an hour I'm feeling worse, that might be more of an immune system overreactivity. There aren't quite as many obvious tells like that for other types of microbes. So if someone had a hypersensitivity to Bartonella, for example, that's not necessarily going to be like a really obvious trigger that like, oh, my immune system is just more reactive. Now, if there's something else that's kind of making the immune system cranky, kind of like stimulating more of that sort of allergic type or allergic hypersensitivity aspect of the immune system, or of that Th2 dominant type of aspect of the immune system, then that might be more of a clue that, oh, we're dealing with more of a hypersensitivity issue. So for example, if someone said, oh, they have a history of like a Bartonella issue, for example, and then they got exposed to a bunch of dust and a bunch of their Bartonella symptoms kicked up, it's like, well, maybe that increase in Th2 overall is causing more of that immune system hypersensitivity to the Bartonella, and then that's driving their symptoms. So again, like with all three of these scenarios, also the treatment that helps with the symptoms would help to give us some sort of hindsight feedback in terms of what was actually causing the issue in the first place. So if a person takes their Bartonella LDI, or they take a Bartonella isopathic, or maybe they're working more with immunomodulators that just so happen to not stabilize mast cells, because some of the best immunomodulators like quercetin also stabilize mast cells, then you might be able to kind of reverse engineer that and figure that, okay, it was probably more of a microbial hypersensitivity. So it's a really good question, really complicated question, lots of moving parts there. If there is a specific, sort of set of circumstances around a patient case where it's like, oh, okay, there are these symptoms and it's happening around this and that, like generally speaking, a savvy clinician can figure out what's probably driving that. Do we need to get some MCAS support? Do we need to get, on top of some antimicrobials, do we need to get into help with some immunomodulation? Of course, many of the therapies we use, like quercetin, they actually would, in some cases, like kind of do all three, because quercetin has some antiviral properties to it. We can usually figure it out in the individual clinical situation, but kind of speaking about it more academically or hypothetically like this, there's a lot of moving parts there. So thank you for the very interesting question. If you have need any further clarification about this, please feel free to post in the comment section below. If anybody else has any questions about this or any other topic, just post below and I'll answer as soon as I can.